Hi, welcome to Mad Medicine with Miss P. Today we're going to just touch on some labs. There's lots and lots of lab values. So today we're just going to kind of start with the CBC, and then we'll get into much more later on, obviously. When you have your patients ordered, when they have a CBC ordered, usually that's obviously we're looking for the cells, those corpuscles. We want to know what's going on there. Their hemoglobin hematocrit, platelets, those are kind of the main issues. You still want to know what all those other letters mean. And I always feel like I don't want to give you the fish. I want to teach you how to fish. So instead of coming up and just asking for the answer, which I'm not going to give you, I'm going to make you work for it a little bit because I want you thinking. I can always just give you a whole bunch of answers, but if it doesn't make sense in your head and you don't know how to get to the answer the next time or the next patient when I'm not there, then how are you going to figure it out on your own or wait for somebody to be able to tell you? So you want to be able to do this on your own. And this is probably the best book I can tell you to have. And it doesn't necessarily even matter what year. This is the 9th edition. I don't even know how old that is. They could be on who knows what. But the diagnostic and laboratory test reference, I used to joke in my IV therapy groups, that's always after y'all have graduated, or some of you LPNs have been LPNs for years and you come back to take this. Yeah, this is copyright 2009, I guess. So obviously, even though I have this book, which is much older than you'd like to have, this is a very beneficial book. And what I like about it so much is that you can look up in the index any name of any lab value or even a specific value. You don't even have to say CBC. You can look up like RDW. You're like, what is RDW? I always see it on the CBC, but I never know what it is. Well, it's that red blood cell width. So it kind of determines the different sizes of these blood cells. And when you have a different size in blood cells, when they're too small or too large, it is indicative of a specific disease. And that's what is so beneficial. You can literally flip to a specific lab value, and then it will tell you if you have an abnormal finding. If it's high, it could be these diseases. If it's low, it could be these diseases. So you could figure this stuff out almost on your own. Not that you don't need a doctor. I'm just saying, if you get a bunch of these lab values and you're like, I can't figure out what's going on, or I haven't been able to talk to the doctor, or they haven't been in to see the patient, you can kind of, if you have one of these, and not that we don't have, Google in our pocket and, a phone in your hand, but you can use one of these to get a little bit better idea of what's going on. And it's really interesting that you can sort of figure things out on your own. And I always tell the story of when I was in RN school, I think it was RN, we had to do these huge case studies. I don't know why we don't have you do them in LPN school, but we had these massive case studies where you had to go through all of the lab values and read all the assessments and get through the chart. You really dug deep. And I remember doing it on my stepmother's computer, where it just had the little green cursor square blinking, because this was 1995, 94, maybe even 93, something like that. So it was a little tricky, but we had to kind of write out all the lab values. And as we're doing this, and I had one of these books, she's kind of typing it all for me and I'm kind of dictating. Otherwise we would have been there for days, or I would have been there for days. So I always remember and thank her for that. She saved my tail in these case studies. So it all had to be, typed up and written. So we're kind of explaining all of these lab values. And as I'm going through, we're like, if it's high, it means this. If it's low, it means this. So I'm going through, his CBC and his creatinine and BUN and all of his lights and everything. And I was like, I think he has acute kidney failure, like acute kidney injury, maybe from dehydration or something like that. And I remember this guy was a roofer. He was like 36 years old, big guy, tan built, and I was like 20 or 19 or something. I had to put a catheter in him. It was a bad experience, but I learned a lot. So I'm looking through this whole thing and I'm like, I kind of think he has renal failure. So I turn in this massive case study and I tell my instructor, Kathy Walsh, who I miss and love. She was fantastic at Broward College 100 years ago. And I'm telling her this and I was like, it looks to me like he has, kidney disease. And I knew nothing. God bless, I knew nothing in school. I'm sure I learned something in school, but I don't really remember learning much or understanding anything until I get out. And then once things are put together and you start to really, comprehend, then you have an interest and you want to put two and two together, and it makes it easier and more fun and more interesting to learn and get it all in line so you can kind of see what's going on with your patient. So she later came to me, and I don't remember if it was the next week or whatever that they found out, and she's like, yes, he was in kidney failure and this is what happened. And I'm sure he was a roofer in South Florida, and it was probably summer, and he literally went into acute kidney injury secondary from dehydration. And that still happens here all the time, but it's usually with an elderly person who won't drink, with dementia in a nursing home with 24-hour nursing care and running water in their room. So not that this guy didn't have access to water also, and he should have been more careful, but obviously after hopefully some good education, he never came back. But this book is kind of the go-to. So when you're talking about your CBC in general, and it kind of starts with your red blood cells, obviously it's a count, right? Because it's a complete blood count. So that's what you're looking for. These are numbers of the amount. So the RBCs are pretty obvious. The WBCs, I think it starts with the WBCs, that's pretty obvious. And that will tell you, obviously if there's an infection or something that the WBCs are elevated and fighting or significantly dropped and we have an immune deficiency issue. And then kind of as you run down that line, there's a whole bunch of other letters and numbers that may not mean a bunch if you don't understand it. So the hemoglobin hematocrit, surely we know what that's all about. And if you don't know, look up what actually hemoglobin does. Read about hematocrit and why they're so important, and why when someone is significantly anemic, we see a drop in H&H, and they're still maybe not going for a type and cross match, or maybe not going to get a blood transfusion, and you can't figure out why. This is why. So those next letters we're coming to is your MCV, your MCH, and your MCHC. And I noticed that just in general, as a young nurse myself, and as nurses I work with in the hospitals, or as an instructor with other nurses and stuff, they kind of get ignored and not paying attention to. But actually, those are the letters that really kind of mean a little bit more sometimes than even your H&H. So your mean corpuscle volume is just that, the average amount of corpuscles or cells. The volume is what you're looking for. So like I tell everybody, it's not your best test score and your low test score that keeps you in class. It is your mean, your average. So that will tell you a lot. So sometimes I see a low H&H, and the nurse that I may be taking a report for, she's like, oh, her H&H is pretty low. She may be, screening for a type and cross match later. And I'm like, well, what's the MCV? And she kind of gives me a look like, what's that? And I'm realizing that they're not even recognizing that. Your mean corpuscle volume is that average. So that might tell you a little bit more of whether they need a transfusion or not. Not that we decide that, but it may explain if and when they're getting one or not getting one, and why. So you also have your mean corpuscle hemoglobin. Obviously, same thing there. The average amount of corpuscles of hemoglobin that your corpuscles are carrying. You need to know that. Your mean corpuscle hemoglobin concentration, and same thing there. That is the average concentration of the amount of hemoglobin your corpuscles are carrying. All of those matter and significantly relate to your H&H and your blood count status in general, your anemia status in general. So a lot of those numbers will make more sense. So sometimes when you are significantly in fluid overload or overhydrated, some of those numbers can be a little off. Like your electrolytes may look a little high or a little low because they're so diluted. Just like in dehydration, they look high because you're so dehydrated. So that mean, or the average, is taken from a different kind of deciliter, well, not a different kind of deciliter, but from that deciliter and counted in a more accurate way, instead of looking at the whole volume that can be misleading depending on the amount of fluid. So your neutrophils, well, that's your differential. Your neutrophils, lymphocytes, monocytes, eosinophils, and basophils, and those are really important to understand also. A very intelligent and still 10-year-old boy trapped in an adult man's body, anesthesiologist, once kind of explained that sort of in like the it's like your white blood cells in different stages of maturation. Not that they're going to grow up to be full-grown white blood cells, but those specific type of white blood cells go out and fight in certain reasons, in certain ways, and certain disorders. So it's really interesting when you look through those to get a better idea of what's happening. So what I saw a lot in the hospital is somebody would come in with let's say a normal white blood cell count, and they have an infection, and they're being treated with antibiotics and that sort of thing, and they're real miserable, and they may or may not even have a fever, but we kind of find a withstanding infection. Maybe it's from the sed rate or retic count or a combo of other things. Maybe they have some long-standing pneumonia, and the white blood cells have gone back to normal. You're like, how could your white blood cells go back to normal if you've got pneumonia? Or Crohn's disease, or HIV, or all these things where the white blood cells have been elevated for so long, and this person comes in and they're like, well, I got a little bit of a cough a couple months ago, and you're like, no, you probably got pneumonia a couple months ago, and you've been able to fight off a portion of it, but your white blood cells are like, okay, I've been fighting for like 6 weeks now, and you know what, no one's coming to help me, so it's almost like they sort of retreat. This is just an explanation to make it a little bit easier without going deep into the lab here. We're just going to get basic instead of getting all chemy. This is kind of the way I explain it to the students, to where I've seen it so often that this is the best way I can explain it. So the white blood cells almost kind of retreat a little bit. It's sort of like your vets that are stuck in a foreign war, and they kind of retreat into caves when they realize that they're out there fighting alone. Well, then when the helicopters start bringing in some additional soldiers and they come out and they see that help is on the way, then they're like, okay, I'm going to roll up my sleeves and I'm going to come back out. And you'll see after the initial dose of antibiotics, or a couple doses, the white blood cells kind of spike back up. And they're thinking, okay, well, if you're going to come help me, I'll come fight the good fight. But you'll see all of the others, that differential, all sorts of out of whack, high, low, high, low, high, low. And when you read specifically, I'm not going to get into detail because Lord knows none of you have that kind of concentration or attention span. But if you get one of these books or Google and you read what those specific phils do, your lymphocytes, monocytes, eosinophils, basophils, and there's another one, neutrophils. When you read about those and kind of see when they're high and when they're low and what it means, you'll find that that's a chronic inflammatory response. Sometimes it's not directly to a current infection. Sometimes it's not necessarily related to infection at all, but it's a chronic inflammation. So there was maybe an initial infection that the white blood cells, your immune system kind of got under control, but it's going to stick around kind of forever, more or less. So some people with COPD, like I said, Crohn's, RA, chronic sinusitis, all of these chronic inflammatory responses, you might see a jacked up differential that's going to be there forever. The white blood cells are normal, or maybe even a little low, but you're always going to have kind of an off differential, and that lets you know that there's a chronic inflammatory response. So when someone comes in and says, yeah, I had a little bit of a cough a couple months ago, but it got better, and then last night it just got really bad. And then I look at the labs and I see the white blood cells are normal, or maybe just a little elevated, and the differential is way off. I know that he's had this chronic infection for a long period of time, and his body's been trying to fight it off, but it's not enough for him to come to the emergency room or to see his doctor until it's, all but almost too late. And sometimes they present super sick, and sometimes they don't, because it's kind of, they've been dealing with it for so long that they don't even recognize it's an issue. Same thing with the diabetes and COPD, where their sats are have to be in the mid 80s before they do something about it, because they're used to being hypoxic and they don't even recognize all those signs and symptoms. Same with hypertension. At any rate, your CBC is kind of the most basic thing that is going to be ordered, and we do it in the hospital when they're acutely ill. We do it every morning at 5 a.m. You're going to see a lot of those, right? And your platelets also, look those up and recognize how important those platelets are. I used to show this video in IV therapy. You can probably look it up. It's on YouTube, I'm pretty sure, and it talks about drawing blood. It's it's a phlebotomy video, and it's made for education, and it's kind of explaining, and the little actors in it kind of stop and explain things in a way that you would never talk to a patient like that. And it's really cute because they do this how not to draw blood, and this just troll of a phlebotomist comes in and she jams the needle all the way up the arm. She leaves the tourniquet on after pulling the needle out and all kinds of stuff, and she's a real jerk. But it's a cute video. But what I like about it the most is it shows the inside of the vessel. Obviously it's animated, but it's the inside of the vessel, and it kind of shows the needle coming in and the blood and the cells kind of going up into the lumen of the needle, and what happens if the lumen is too small, and how they will kind of explode on impact. Lysis, they'll kind of the cells won't survive if you don't use a large gauge needle to draw blood and that sort of thing. So it's really neat from the inside. But what I like is that when they pull the needle out, it shows how the platelets start to kind of form a little bit of a mesh, and then all the other factors. Now, granted, they don't show specific factors, but they just kind of show the platelets kind of come together and start to form a little mesh. And it's just a neat little illustration of how important platelets are and what they do in that hole that's created, or when you have a risk of a bleed or a beginning of a bleed, how the platelets kind of come to save you. And it's a really neat little visual to really understand what platelets do. They kind of look like, in this video, they look like little spiders. They kind of have little legs on them, and they start to aggregate, and that's just what platelets do, right? So platelets begin the aggregation, and then all the other factors kind of fall in line until you end up with the end of that ladder, which is your fibrin clot. So it's just a neat little video. You can look it up on YouTube. I wish I knew what it was called. It's phlebotomy, the best phlebotomy video, and it's made pretty well, but I'm sorry I don't have the name of it. I didn't think about it until just now. I don't prepare for these at all. I just kind of come up here real quickly and think about what I want to spit out to try to help y'all a little bit. But my fishing education here is really trying to teach you how important it is to look up what those numbers and letters mean. And if you don't know what they mean, take a minute, grab a book or Google it, and make sure you understand what all of those different letters and numbers mean. And I'm sure there's a couple other things on the CBC that I skipped over. This one may not be a complete list, but it's just a really good, simple how-to, and I want you to really understand how important it is that you get to your own answers to your questions. It seems like it's real easy to just ask somebody, but if you haven't already asked somebody to where you've said, like they've answered you, and as they walk away, you're like, okay, thank you, but inside you're thinking, I don't really understand what you just said, or it doesn't make sense, or you almost want to argue a bit, then that's kind of where I am, and I don't. If someone's going to give me an answer, I want to be able to say like, oh, okay, that makes good sense. If I still have stuff to look up or try to understand, then it doesn't make sense to me. See, this is what we see now with the differential is it's the whole CBC. Then if they ask for a differential, that's kind of your neutrophils, lymphocytes, monocytes, eosinophils, basophils, kind of at the bottom. But I don't know why I don't have an example. But if you Google it right now or look it up, you can get your full list of exactly what's on a CBC. I'm trying to go off of memory here, that after your MCHC, your MCV and all of those, I know the width is in there, and then there's a couple other things than your platelets, but I can't think of it right now. But if you don't know what those letters or numbers mean, look them up, and you might say like, oh my gosh, that makes perfect sense, because I had this one patient that this was a situation. Or when they're abnormal, you want to know what that means, and if they're normal, you kind of tend to look over them, but when they're abnormal, that's when it makes more sense. But if you've got a minute, take a second and look through them and see if you can't figure out exactly what those numbers and letters mean. And that's what I had to do. I just had to stop and look these things up. We'll talk more about reticular count and SED rates. We'll get into a BNP and a BMP, that basic metabolic panel. We'll go through electrolytes and that sort of thing next video, and that will be in about 2 weeks. So I know the 6 of you still watching may miss me terribly, but I will try to record on July 5th, and then I'll upload it July 6th. I'll be out the next 2 weeks. I got some a little staycation and a couple other things to do, so this will be the last one for a couple weeks. Try not to miss me too much. And my pet peeve for today is don't wear pajamas in public. There's never a reason to do that. I don't care if you're having surgery or just run into Walmart, run into Dollar General real quickly. Just please don't. No, pajamas are to sleep in or to lounge around the house in. There's never a reason to go outside in pajamas. I know they're comfy, but so are sweatpants. Yoga pants are comfy. Just wear a shirt that hides, your cervix. But there's never reason to wear pajamas outside. And when you do, all I have to do is hear it from my husband, who is mortified and disgusted by all of those wearing pajamas in public. So it doesn't necessarily bother me so much. You wear what you want to wear, and I'll just divert my eyes when things don't fit quite right. But it does drive my husband insane, and then I have to hear him complain. That's why I don't go to Walmart with him anymore. I can't deal with it. It's torture for him. It's torture for me. So let's not do that. Okay, so like always, face your fears, forget your failures, and follow your faith. And that goes for everybody, because we all make huge mistakes, and it sucks when you do, but we're human, and I am too, despite popular belief. So I'm going to try to have a good rest of the week, and I hope you do too. Miss you guys. It's never going to work. It's never going to